They start with the nasopharynx. We have a data here from University of Pittsburgh again, and we boost all the nasopharyngeal tumors, especially close to the base of the skull. Local control is excellent. They have actually, I think this is up to 40 years now, local control 95%. There is a Dutch trial, because back in the day you used to put implants inside, brachytherapy. So they compared boost treatment, which is non-invasive, you don't touch the patient, no anesthesia, versus the boost treatment, and the local control disease-free survival, although the survival is excellent, and both are the same. This is actually, as of 2013, where happening all over Europe and America. Publications come up with the radiosurgery as a booster for these treatments. I just needed to see how much beautiful the local complete response, partial response across the trial. Local controls are much better now with adding SBRT. Toxicity is very low in relation to this treatment, even though you can give very high dose of radiation. In North Shore, we start a protocol in 2010. Patient was oropharynx, HPV negative, or they smoke more than 10 years. These are the two bad prognostic features from the New England Journal of Medicine trial from the RTG. We do very bad. So these patients, we actually give them regular external radiation to treat the nodes and the microscopic disease to 60 gray. We save the organ of the swallow and the pharynx as much with systemic chemotherapy. After 60 gray, we do an MRI, and then we do SBRT treatment to the tumor. We start with a dose of 8 gray, one shot, then we increase it after 15 patients to 10 gray, and then we're going to increase it to more to 15 gray as the trial goes. We completed actually the first arm of the trial, 8 gray single fraction after 60. We have a decent follow-up up to 8 to 10 months now, and I want to present my data. So the trial actually endpoint was 3 questions. Toxicity, how much toxicity you add to the patient, how much benefit local control, disease-free survival, overall survival in 2 years, and then we also assess all the quality of life, their salivation, the swallowing, salimetry every couple of months, so you see how much they recover and they go back. So in a nutshell, patient comes, we give them 60 gray to the tumor and the lymph nodes, and then our tumor itself, we boost it more, those 8 gray more as a booster with radiosurgery. You notice now the advantage of radiosurgery. If you look at the doses of the radiosurgery, it doesn't go to cover, like it's very limited. No much spillage around the area, so you don't add more radiation or SBRT. It's a very focused treatment. The radiation doesn't travel outside. So this is one of the beauty of radiosurgery in the head and neck. So you don't add toxicity, and we're going to see now. So we had 15 patients, 12 patients were ready for evaluation. Grade 1 toxicity, which is mucositis, happened with radiation first 3 months. It doesn't change much, which is happening every time because you treat the pharynx and the nasopharynx. Late toxicity, let me show you what we did. Out of 12 patients we treat, only 5 need feeding tube, and it's actually for 2 months, and then he recover and start eating. So at the end of 90 days, we have 0 feeding tube, 1. Grade 4 toxicity, we have 1 patient, and actually the tumor is so thick, so when it's necrotic and collapse, we have a big necrotic hole in the pharynx, and he bled from it, which is something you start noticing because there's too much cell death and apoptosis. You leave a hole on the tumor, and a lot of centers studying this toxicity now. It's only 1 patient though, and we have to get the surgeon to do patch with the skin patch inside his pharynx, and he's eating now. So, as of 7 months after treatment, we had 3 incidents. Number 1 patient which have failure, distant and local. He have more chemotherapy. Second one, he have a very bulky disease. It's actually he aspirated and died. And the third one have residual disease removed by surgery, and he's alive and doing well almost a year now after treatment. In conclusion, HPV negative child disease, it's a very bad, poor prognostic disease. We have 50% less survival, local control, opposite to the HPV positive. It needs intensifying the treatment, chemo, and radiation. SBRT have a good rule on it. We still accrue on our patient protocol, and we try to tailor the treatment based on the patient's HPV status, personalized radiation. Thank you, Jim.
As a result of a coherent policy in detection and treatment of the breast cancer, we succeeded in shifting in the treatment of this disease from about 20% of radical mastectomy, that was the main procedure for surgical treatment of breast cancer, to about 75–80% of conservative treatment today. The best tool used for the detection of the breast cancer is mammography, and it is probably the largest method to detect breast cancer in Romania. But step by step, the younger generation of physicians trained in ultrasound are able to detect in younger patients much cancers in young patients. MRI is not very largely used in Romania because there is not a large experience, and also because the number of machines are limited. The mammography is the most reliable means of detection of the breast cancer before the tumor is palpated. Most of the machines are classical one, but there are a lot of digital machines. And finally, we believe that a good mammography could use detection of the occult breast cancer, no matter it is a classical film or a digital one. The most important images of the occult breast disease, breast cancer, are the microcalcifications that are known by images physicians, also by the surgeons and medical oncologists. And these are cluster or polymorphic microcalcifications with different forms like V or shape, or IY shape. Also there are a parenchymal distortion and the mass density with, in a case where there is no calcification or irregular borders. In difficult cases, we could use supplementary mammography or additional incidences, and for solid tumors, local compression and microcalcification could be also better viewed using the zoom. The breast cancer is a multidisciplinary approach, having at least a breast surgeon, radiologist, pathologist, and medical oncologist. And the most important decision is a team work with involving all these specialists and having a broad tumor to decide the best attitude in every case. The most frequent method to detect the breast cancer are the mammography and the ultrasonography. And we use, in the cases that were detected by mammography and ultrasonography, localization of this occult disease by preoperative needle localization using the wire hook. The localization is performed in most of the cases by ultrasound, and in some of the cases using the mammography. Putting a needle into the breast is very important, and the cooperation between the surgeon and the radiologist is important in the way they put the needle, in the way the surgeon will excise the lesion, and in the way it is estimated that all the microcalcification, for instance, are removed. Excision biopsy of the excisional biopsy with a needle localization implied a complete removal of the breast lesion with a margin of the normal appearing tissue, and the frozen section also confirmed that the lesion was completely incised in healthy tissue. Localization is done by mammography or ultrasound, and it is important that the lesion have to be accurately localized. This is the way we put the needle by ultrasound into the tumor, and there are some small tricks in the way we put the needle into the middle of the tumor or passing through the tumor. We prefer to put the needle passing through the tumor in order to facilitate the complete removal of the lesion. After the lesion was removed by surgery, the specimen is sent to the radiology in order to perform a radiography to show that a complete lesion was excised or the complete area of microcalcification. These are some practical images from the practical activity. This is a needle localization before surgery. As you can see, this allows cosmetic surgery. This is the incision and also the surgical specimen removed. The post-operative specimen are sent to the radiography, and it is seen that the whole lesion or the complete area of microcalcification is on the mammographic film. And this is the final results after surgery. We could put in the breast 1 or 2 or even 3 needles in order to localize different lesions and to perform, when it is possible, conservative surgery. The incisions that are recommended are circummeral one in the upper half part of the breast, and radial incision in the lower part of the breast. It is important to keep the biopsy incision within the boundaries of the skin excision in order to allow a possible mastectomy if it is necessary. We don't recommend radial incision in the upper part because ugly scar, and also a circummeral lesion in the lower part of the breast because of the same reason. Breast conserving surgery consists in local therapy and systemic therapy. The breast surgery is important in order to control the local disease, and axillary surgery in order to evaluate the extension of the disease. Breast surgery continues to be the standard of care, and we prefer from all kinds of definition used to name the surgery, we prefer to use wide local excision. We don't perform quadrantectomy or lumpectomy. Axillary surgery continues to represent a standard of care in definite circumstances. We currently perform sentinel lymph node biopsy, and in clinical positive axilla, I prefer to perform clearance of the axilla. But we discuss with our colleagues the possibility to limit the number of cases with axillary dissection, because there are some studies showing that we could avoid this step of surgery. We try to discuss to put into practice a new study of the American College of Surgeons showing that if the axilla is negative and this is established by ultrasound, we could avoid safely the lymph node dissection. We don't perform lymph node dissection in case of isolated cells in the lymph nodes detected by sentinel lymph node biopsy, and also we don't perform axillary dissection in case of lymph node positive at immunohistochemistry. This is the way we perform the sentinel lymph node. We don't use the colloid technique, we use patent blue dye. And as everybody knows, breast cancer is no longer considered a single disease. There are different subtypes defined by genetic testing and immunohistochemistry, and these subtypes of breast cancer have different epidemiology, risk factors, different natural history, and different responses to local and systemic therapy. Most of the cancer detected as a cold breast disease are ductal carcinoma in situ. This represents about 25 to 30% of the whole breast cancer, and the treatment is in most of the cases a conservative one. There are a few cases in which the extension of the lesion could not allow the conservative treatment. If the ductal carcinoma in situ is not completely excised, the risk of recurrence is quite highly, at about 50% of the cases, and this is, in most of the cases, an invasive cancer. So, the standard of care is a wide local excision with negative margins. Mastectomy is indicated in the case of extensive intraductal component, or is a contraindication to perform a conservative surgery. Adjuvant radiation therapy is considered also a standard of care in order to reduce the recurrence and also to increase the survival rate. Axillary dissection is not included as a part of the ductal carcinoma in situ, and the sentinel lymph node biopsy is indicated only in high-grade disease locally treated. In the case of radiation therapy, most of the case, this is a problem in Romania because radiation therapy is difficult to be covered for all the patients in need. So in most of the cases, we prefer to show patients to the radiologists that are familiar with this kind of treatment, because in most of the cases it is necessary to avoid the axilla and to perform a tangential radiation of the breast. There are also different studies showing that the radiation of the breast could be avoided in older patients with the same rate of cure and risk of low risk of recurrence. Breast cancer today is faced with a new paradigm. The breast conservative surgery continues to be a standard of care, and also the X-ray dissection is limited to the patient that have clinical positive nodes or where the sentinel lymph node is positive. The medical treatment have to be personalized, and it is possible to test by immunohistochemistry and by genetic test every patient in order to consider the possibility to treat in an individual way every patient. So, the breast cancer is not a single disease. It has a gene signature, is a spectrum of disease with different subtypes that may be approximated by clinical pathology examination, by gene expression, and also they have different epidemiological and risk factors, different natural history, and different responses to local and systemic therapy.
If you have a tumor and is treated by medical oncologists, they make some cycles of chemotherapy, and tumor grows again. And what is your attitude against this situation?
We have sometimes these cases that don't respond to chemotherapy, and in this case we prefer to perform a mastectomy.
Choose to be operated for
T1 tumor in Vienna. And she asked me on phone in that day, here is a questionnaire, and the surgeon asked me, will I accept a sectorectomy or total mastectomy? Why? Because my tumor is 9 mm. And I said, probably because we know 10 or 15% are multifocal. She accepted radical, and we discovered on Oncotype DX sent in America that it was a very, very high risk tumor. So she underwent chemotherapy, radiotherapy, and so on. And because it's high risk on Oncotype DX, what happened after 2 years? She had in the contralateral breast cancer, despite of her hormonal treatment and so on, or for not ectomy, but chemically, she developed another tumor, HER2 positive this time. So my question is, always we ask for local treatments, not so radical surgery, only sentinel node biopsy, not to have many complications, and it's a protocol. Do you accept radical? How we can choose these cases? Because in 9 mm, in Romania, I know few persons to make a biopsy, and I don't know if it is indicated. We send directly to you. So for me, it remains a question.
Thank you. There are multiple questions, well, many questions. The first, why the patient was asked radical or conservative surgery? The surgeon is not the person who decides for the patient. The surgeon is the patient informing. The surgeon is the person informing the patient. So, even if I strongly believe in conservative surgery, I don't decide for the patient. I represent the patient all the alternative risk and benefits, and the patient will decide. But if I'm certain that the conservative surgery will be benefit for the patient, I will encourage her to do that, not imposing a decision. This is the first answer. The second is related to a very rare situation of high-risk tumor. You didn't mention anything about lobular carcinoma or ductal carcinoma. Ductal carcinoma is rarely multifocal. Lobular carcinoma is frequently multifocal. So, if it is a ductal carcinoma and local excision was recommended, was chosen by the patient, was probably the right decision. But the patient developed another cancer in the opposite breast is a matter of risk, and is a matter of what I said before. There are different subtypes of cancer, not only one cancer. There is a poor prognosis, but is related to the very rare and very specific situation. This is not an explanation to compromise the conservative surgery of the breast and to promote a more radical. This is a very strong studies showing that conservative treatment and local treatment have the same rate of control and very good decision taken. Thank you.